The objectives for this session, if you're a pharmacist, it would be to describe the goals of the ASHP and the ASHP Foundation Practice Model Initiative, discuss implications to health system pharmacy practice, and identify steps that we all as practitioners and hospitals can take to support this initiative. If you're a technician, you again should be able to describe what the Practice Model Initiative is, discuss the implications to health system pharmacy, and again explain implications specific to pharmacy technicians and the Practice Model Initiative. All right, that being said, so really, what is a practice model? And really, a practice model describes how a pharmacy department deploys its resources to provide the best patient care. We all have to realize that one size does not fit all. Later on in the presentation, I'm going to give you some examples of how we at my facility have been handling and rolling out and changing our practice model. But it by no means is the only way to do this or the only model that fits. And finally, for the ASHP practice model, we believe that it must include how pharmacists practice and provide care to patients, how technology is involved to support that care, and how we use automation and technology in the medication use system. So those are really the three components. They're like the three-legged stool, and really, you have to grow both pieces. You have to address both pieces in your practice model. So the vision that was developed before the summit even was transpired in November, the vision was to create an initiative in the summit that will create passion, commitment, and action amongst hospitals and health system pharmacy leaders to significantly advance the health and well-being of patients by optimizing the role of pharmacists in providing direct patient care. And I think that there's, a key message here is that it really talks about accountability for us as pharmacists, for us as pharmacy leaders, and for us as any other practitioner within our pharmacy department, to really lead and advance the well-being and the health of our patients by being accountable for that and being accountable for optimizing how we use our resources to provide good patient outcome. There were 5 objectives created around the PPMI. The first was to create a framework in which pharmacy practice models can ensure the provision of safe, effective, efficient, accountable, and evidence-based care for all of our patients. The second objective was to determine patient care-related services that should consistently be provided within departments and actually even requested by or expected to be provided by patients, caregivers, and other healthcare professionals. The third objective is to identify the available and emerging technologies that can support our ability to implement those practice models. The fourth objective was to actually develop a template for practice models that support optimal utilization and deployment of our resources. And when we talk about resources, we talk about not only our resources as far as human resources, but also our resources related to technology. And the fifth objective is to identify specific actions that pharmacy leaders and pharmacy staff should take to implement practice model changes, including what is the necessary staffing to support the appropriate practice model in your setting, as well as what are the skills and competencies needed to achieve the patient outcomes that we envision with our new role. If you look at this, this shot, it really is, I apologize, it looks like it's a little bit off. That's prescribing is the first area. If you look at this is a typical depiction of what the medication use process involves. It's prescribing, documenting, dispensing, administering, and monitoring. I think all of us have probably seen these buckets. But what this really tries to highlight, if you look on the very bottom, is that we really need to focus our efforts with our pharmacists and their core skills and clinical abilities on the prescribing and the monitoring piece, while we utilize our technicians and our technology to support the middle piece, which is the dispensing piece. So that's really the basic premise of where we want to go with our practice model. So what are the imperatives? What is driving us to want to say we need to change? Because nobody really likes change. And really, there's a lot going on out external to us, if you will, in hospitals and within health systems. Certainly can't highlight, and we can't spend the next hour and a half even trying to delve into healthcare reform, some of which I don't even think we know what's going to happen. But certainly that's a driving environmental factor that's forcing us to take a look at what we do as a profession and how can we support the new healthcare reform. The continuing medication crisis. I would hazard to bet there's no one in this room who hasn't heard about the fungal meningitis outbreak and the issues that that's been causing across the nation. Certainly, I would consider that a medication crisis. What are we doing to assure safe product for our patient? But you can take it back even further. Years and years ago, I can't remember exactly how many, probably close to 10, when the IOM came out with the first report that talked about medication errors and patient harm. So there certainly continues to be a crisis related to medications, whether it's patient adverse outcomes, poor compounding practices, drug shortages. The crisis just keeps mounting on us. There are a lot of stressors in hospitals and ambulatory care that are really starting to force those two separate entities, if you will, more in a collaborative approach. The lines are going to start to get blurred, I believe, between hospitals and ambulatory care, which is really going to force us to think differently. And it's really going to force us to think differently in how we reinvent acute care. We are a very expensive commodity if you look at our total gross national product and how much is spent on health care. So we really will need to reinvent acute care. There's an imperative for teamwork. There's an increasing need to have a multidisciplinary team at the bedside, managing the patient at the bedside. And we as practitioners need to make sure we're part of that multidisciplinary team. And how can we make sure that we're there along with the physician, the nurse, the care coordinator? There is definitely a need for clinical and strategic integration. Many times the business component doesn't interface well with the clinical component. I think somewhat in healthcare, but we can certainly probably look in our past lives back over the past years that sometimes the enterprise, the business development in a pharmacy program doesn't always, or stands in silo of our clinical processes, and those two need to really converge. Certainly the economics are driving us. The expenditures on healthcare in this nation are on a steady increase to a point where the government, affordable healthcare, thinks we can't afford what we currently have. So the economics are driving a practice model change. In addition to that, as a pharmacist, we're an expensive resource. So in light of trying to cut back on healthcare costs, we need to make sure we demonstrate the value of the dollar you're spending on us. And finally, technology is changing at a logarithmic pace, I believe. I am just amazed. When I started out practicing, we had manual profiles that we were writing on, and now I've got physicians typing the orders in the computer. It's quite interesting how fast technology is changing. There are other imperatives for practice change, really, that are directly impacting us. Certainly, all of the changes we just talked about in healthcare are forcing us to think about our practice models. What value do we provide to those? And we now have an increased availability of trained pharmacists who've gone through one-year residency programs. I believe the latest number I heard was we have well over 2,000 graduating on a yearly basis from a PGY1. That's about equivalent to the same number of pharmacists graduating when we used to have 75 schools of pharmacy who wanted to go into hospital pharmacy. So we are really seeing quite a change in our trained and skilled pharmacists. And we need to make sure that we are rationally using those resources because, again, we're an expensive commodity. I'll just be blunt. We're expensive. However, we certainly demonstrate value. And ASHP and the ASHP Foundation commissioned Marie Chisholm Burns to do a meta-analysis of all the literature that was out there demonstrating the value of pharmacists. And this is a well-published article. It was done, I believe, in 2010, just before the PPMI Summit. Might have been released a little bit after that. And really, the purpose of it is to provide a tool for us to present and demonstrate the value that we provide, the value back from investing in us and our resources on patient care and outcome. So it's a very, very, very well done meta-analysis. If you haven't read it or haven't used it to advance your practice model, I certainly would encourage you. So, the PPMI Summit. There was a summit held almost 2 years ago from almost the exact day. It was in November. of 2010, and it comprised about 100 invited attendees from across the nation, from all different practice settings, to come and go through a consensus building process to determine what did the practice model look like. And prior to that, there was a survey that went out nationwide to a whole host of larger audience to determine some things, some statements, their responses on statements. Anything that didn't get full consensus or more than 80% of a consensus vote from that broad survey then came to the practice model summit, where there's 100 individuals to debate it. Do we agree with the statement, if you will? Out of that summit and the survey came 147 beliefs, assumptions, and recommendations. And those are published. They're available through ASHP. And what they focus on are imperatives for change, statements that relate to imperatives on change, statements that relate to optimal pharmacy practice models, statements related to technology and technicians, and statements related to successful implementation. Now, we're not going to have time to really go for every single 147 beliefs, assumptions, and recommendations, and I think that you'd probably be happy to know we're not going to do that. But we are going to highlight a few key ones and then speak in a little bit more depth about them. The summit proceedings were published in ASHP in 2011, and there's a series of articles, primer articles, that the participants read that were very, very thought-provoking. And I would encourage you, if you have not read those summit proceedings, to go out to the journal and find those and read through them. But they really talk about, in more detail, why do we need to change our practice model, what are the characteristics and requirements, and what are the challenges that could really surround us going forward. What is it about information technology and meaningful use in the medication use process that we need to be concerned about or think about how we can advance our role using that. What about advancing the use of pharmacy technicians? What's that all about? And then finally, some articles and some information on how you successfully implement pharmacy practice models. So we're going to go through a few of the imperatives that were surveyed and or discussed by the PPMI. And just kind of take a look at a few of these things. And I guess I'd like to do a little bit of polling from all of you to see what you feel, if you agree with this statement or not. So the first statement I would like to kind of poll you about is that hospitals and health system pharmacists must be responsible for and accountable to patients' medication-related outcomes. How many of you support that statement? Oh, good. You're consistent with the rest of the nation. We voted a consensus of 96%. So I think that this is important because, again, we really, really want to stress that we are accountable for those patient outcomes. Next imperative. Over the next 5 to 10 years, hospitals and health system executives and medical staff leaders will expect pharmacists to help ensure compliance with quality care standards. How many people believe that we're really going to be asked to come to the table and support value-based purchasing, core measures, all of those things? Raise your hand. Yeah, pretty close, about 93%. So that's another imperative. So think about those things and think about how we used to practice about 10 years ago. Quite a bit different. Next imperative. If optimal practice optimal practice models, pharmacists should not be engaged in drug therapy management without an understanding of the responsibility for the medication use or delivery system. So really, you can't practice in isolation and not know the entire part, the entire package, the entire ability, or the entire process for the medication use or our delivery systems. True or false? Anybody agree with that? Okay. Yep. We had about an 85% consensus vote on that. Then let's look at a few of the statements related to optimal practice models. The first one being, pharmacists who provide drug therapy management should be certified through the most appropriate Board of Pharmacy Specialties certification process. How many believe that this is to be true? That if you're going to be responsible, you need to be certified? Oh, a little bit less. Okay. What do we think nationally? 82%. Okay. think we got a little bit of a discrepancy between all of us and what we felt nationally. Next statement related to optimal practice models. All distributive functions that do not require clinical judgment should be assigned to a technician. How many agree with this? Oh, more. Consensus was 93%. To support optimal pharmacy practice models, technicians must be licensed by state boards of pharmacy. This one, I believe, is a little bit more controversial. How many agree in licensure? Oh, that's pretty good. Okay. Consensus was 93%. Okay. All right, now we're going to talk a little bit more in depth about the barriers that were identified through the summit process. And the first barrier I'd like to talk about, and the statement is that, or the first barrier that was identified was that the pharmacist's commitment. And the statement was that there is resistance to change from current pharmacy staff, and it is a barrier to optimal pharmacy practice models. How many of you agree with this statement? Sadly enough, 100% of the people believe that this is one of our top barriers. So, I guess what I'd like to reiterate, and I was thinking about this the other day when I was working on another initiative. If you think about it, and you think about all the external factors that are forcing us, if you will, or challenging us to change our practice model between ACOs, healthcare reform, economics, technology. Those are all external forces that we have no control of, right? And it is really challenging us to think differently about how we practice. But our biggest challenge is stuff we can control. So I think we're our own worst enemy, to be honest with you. So I think we need to really think about that. The piece that we control is the challenges, not the opportunities. So I think that's kind of an interesting way of looking at it. So I'd like to talk to you a little bit, I'd like to sidetrack and talk to you a little bit about what we've done at Beaumont. Again, one size does not fit all. I'd love to hear everybody else's stories. We all have different stories, but just to give you some ideas of what we've done at my site to try to address some of the issues with pharmacist commitment and our practice model set initiative. We really believe, while we've been evolving our practice model, that we need to connect the pharmacist to the health system goals. And we do this by educating, communicating, many, many ways, over and over and over again, showing our staff where we're at with value-based purchasing or HCAP scores in the areas that they're working in. We really think we need to continue to communicate that. We feel like we communicate a lot, but it certainly isn't never enough. We also need to bring meaning on why things need to change. People feel comfortable with the status quo. Why do we have to change? So it really is all about talking about, we're not entering orders anymore, we're just validating. The computer system's pretty smart. Pretty soon it'll be able to calculate the dose for the doc, and we won't have to be doing that. But we can bring other value. What are the needs of your current patient population? I'm going to talk about this a little bit more specifically, and this is what really started to help us fine-tune our practice model and making it much more meaningful for our staff. We also, and I'm going to speak about this a little bit further, involve our staff in multidisciplinary meetings that relate to their practice. We have a mixed model. We have about 22 clinical pharmacy specialists who are mostly PGY1 and PGY2 trained, and then we have about 70 staff pharmacists. Our model has always been pretty much that the involvement in multidisciplinary meetings and committees and all of that involvement rests with our specialists. We realize that can't work if we want to change our practice model when we have 70 other pharmacists who we need to have engaged and participating and helping us change. We need to bring them to the table too. So we really found that. Now, it's not easy. It's a challenge, but we've started making some progress in that way. And then finally, we really realized that we need to let the staff lead some of the initiatives. They need to own it, they need to lead it, they need to come up with the ideas. So We've done a lot of cultural change at my facility on really engaging frontline staff in making changes on problems that they occur, and we've carried that through into the pharmacy department. A few other key lessons. These are bolded because I think these are really, really important. And I think once you hear our story, you'll understand what I'm trying to speak to. It is not a quick fix or a change. We have been at it for several years. It takes time. And where you start is not going to be where you end, and you're going to see that in our story. So don't be disappointed if it fails initially or doesn't come out like you wanted it to. And again, I can't emphasize this enough, that it must be staff developed, it must be staff owned. So, Beaumont Health System is a 3-hospital organization today, in case you saw the news earlier this week. That could change. But right now, we have 3 hospitals in the system. And if you haven't heard the news, talk to me later. It'll be fun. I'm going to speak at our site. We are the largest facility. We're located in Royal Oak, Michigan. We are licensed for 1,061 beds. We were the first magnet facility in Michigan. 57,000 admissions, 120, these are annual numbers. 120,000 ER visits, 52,000 surgeries, and we have more than 400 residents and fellows. We are the only level 1 trauma center in Oakland and Macomb County. 92 adult critical care beds, about 50 progressive beds. We have a full children's hospital within a hospital. Pretty much have every type of patient service, with the exception we do not have a burn unit and we do not do bone marrow transplant. So complicated. We are complicated, and we are spread out all over the place. We have had clinical pharmacy services well established, very good services for years, probably 25, 30 years at Beaumont. And certainly they were the very typical clinical services that most of us are comfortable with in acute care related to pharmacokinetic dosing and anticoagulation monitoring. So those were our typical services. We had pharmacy satellites sprinkled throughout this very, very large footprint. And that started to change. In 2004, I believe it was 2004, we built our new South Tower and started going to more of a cartless model, which made us question, do we need all these pharmacy satellites? And we started collapsing pharmacy satellites. We built a new central pharmacy. We centralized. We built a brand new super satellite, which was located kind of in the middle of the hospital, and really started to pull in a lot of our dispensing activities. And what we found was that we changed our processes from an operational standpoint significantly, and we kept our pharmacists on the floors, but they were still just doing dosing services. So they were running all over the hospital doing dosing services. And what we lost was that connection with our staff and the nursing units, because we didn't have those little satellites where you have, you know, a small group of people that are really used to those nurses and they develop great relationships. We made a mistake well, we had a lapse, I will say, and we lost that connection because most of our staff were then back in more of these centralized areas. So we, in 2010, the middle of 2010, we had a new hospital president, and he really wanted to change our culture and change our organization around. And we started a pilot project on one nursing unit with a new nurse manager and a new process related to the Toyota production system, which I'm not going to go into, but it's all about change and ownership and staff development through that change process. And the nurses started looking at what the goal was that the hospital president established, which was to increase the nurses' time at the bedside. And it was sad, but it was very repeatable in other areas, but the nurse was only spending about 23% of their time at the bedside. And we really felt for the best care, we needed that nurse to be spending a lot more time at the bedside with the patient. So the nursing unit took on improving everything that they could own within their nursing unit to stop the interruptions and stop the nurse from not having time to spend with the patient. And they did everything they could that they felt that they could on their own, and then they started pulling in departments that were causing them problems of why the nurse couldn't spend time at the bedside, and yep, I got it. missing meds, and, so I kind of knew it was coming. So we started getting involved with that nursing unit and doing some small changes. And then we sat back and we said, if this is the hospital's goal, to keep the nurse at the bedside, we need to be on the unit, and we need to be immersed in the unit. We need to go back to not just running around doing kinetics and having our rest of our pharmacists in locked rooms, if you will, doing order entry and dispensing. So what we did is we piloted on that one nursing unit that was trialing this new process improvement methodology. We piloted having a unit-based pharmacist there. And with the goal that that pharmacist would be available for the nurse, would do, at the same time, believe it or not, we went up with physician order entry. So that allowed us to be a little bit more freed up and work on any computer. So we we had a core group of about 4 or 5 pharmacists that really developed the project of how they could assist the nurse. Then we started looking at HCAP scores and saying, gosh, we should be educating patients. We need to meet with every patient. So we started developing a very, very nice practice setting where the pharmacists were well accepted. It was a great relationship, worked phenomenal. We said, wow, this is where we want to be. This is it. And so in 2011, we spent some time, and we expanded that model throughout the hospital. Pretty much, not 100%, pretty much. We expanded the model, and we said, wow, here we are. We also added technicians to our unit-based service model with the thought that our technicians could help with the missing meds. We don't want to tie our pharmacists up chasing missing meds. We want them to be utilizing their clinical skills and working at the top of their license. So we put technicians on the unit. So we said, oh, we've got it. We've changed our practice model. Then we started hearing some rumors. We started hearing some things, and we realized, what's going on? Wait a second. The pharmacists now are collaborating and switching off the dosing service so that we've got still a couple people only doing dosing and running around the hospital, and the other people are not doing that. We wanted them to look at the whole patient. And we started following our pharmacists and going up to the nursing units, and we realized that they really weren't engaged with the nursing staff. They weren't able to accomplish what we wanted to. They weren't owning or feeling a part of what we felt needed to happen in our practice model. So we took a step back and we said, what did we do wrong? And what do we need to do that's right? And where we landed is that in early 2012, what we did wrong was that you as a pharmacist could be assigned anywhere in the hospital. You didn't have ownership of a specific patient population. And that's really hard to connect with a group of nurses if you haven't seen them for 3 or 4 months or have never seen them. And you may not know what's going on in that unit. We also tried to standardize that if you're going to do, if we were going to roll out a specific program, it would be the same for every patient population. And that it just didn't work. It failed. Or it wasn't the program that we envisioned. So we refocused. In early 2012, we developed communities of pharmacists, which is a group of pharmacists that will be assigned when they're doing their unit-based service rotations to those specific nursing units. So you have much more consistency with a smaller group of individuals. And we then challenged those pharmacists and provided them tools and paved the way. And this is not a fast process, but it's moving, to develop services specific to their patient population. We couldn't pigeonhole everything. We also wanted them to be involved in, we would pull them in multidisciplinary meetings. So we have different centers of excellence that my one assistant director would go to, and so she would pull staff pharmacists who work on our orthopedic floor to the 1-hour Center of Excellence meeting for orthopedics so they could see what's going on around the table and what the problems are that we as a health system are being challenged with and what are the goals of the orthopedic service. So then when they go out, they go, wow, we need to develop a mechanism to help teach our patients about pain control. So we did all that, and we also provided tools. And my one assistant director, Diane Rakowski, I have to give her all the credit for this. She is just taking this and just moving it forward. And so we started this in early 2012, and I would say it was pretty successful even at the very onset. By April, and I just want to read to you, she sent an email To our entire staff, just summarizing where we were so far after only a few months of this. And I'll do it real quickly. Group 3, who work on 8 North and 9 North. The pharmacists are involved in various committees planning the opening of the adult care for the elderly unit on 9 North. It's called the ACE unit. Future pharmacist activities that are being developed would be rounding with the ACE team, developing medication protocols, medication counseling for patients and their families, med rec at admission and discharge, and providing discharge meds for patients. Group 1, which is the 5 North, 6 North pharmacists, are partnering with the pulmonary nurse clinicians and social workers to provide patients on the pulmonary mobility unit with education and help with the prescription assistance programs with the goal of decreasing readmissions. We're also working on a program to dispense bulk products so that when the patient goes home, they have their medications with them. And finally, Group 5 pharmacists are developing a system to identify patients for discharge counseling and skip measures, measure compliance. The nurses are starting to use patient counseling referral forms to notify the pharmacist of patients needing med counseling. Most of the unit-based pharmacists have met with the nurse manager responsible for their nursing units, and the plan is to develop a collaborative strategy to improve med safety, patient satisfaction, and transitions of care. So this is exactly where we wanted to go, and it was really cool because our pharmacists really started to get into this. It was really, really neat. And so they started developing these programs. Well, can you imagine? Diane was like, oh my gosh, I've got all these programs. How do I manage this? And how do we keep everybody updated on what we're doing? So you can't read this, but it's a very, very detailed grid of what we first started. So these are all of the different initiatives that are started, that we're working on along here. And these are all the different nursing groups. And this is, are we doing it in this area? It's checked off. So some places we're doing the same activity. And in other places we're doing just 1 or 2. So for instance, for our acute coronary syndrome patients, I think it's this one right here, the patient cannot be discharged until a pharmacist reviews the chart to look for the ACEs and the ARBs. So we've got some very detailed, specific things. We're working on some pain protocols. I think they're close to being rolled out for our orthopedic population. And then we want to do additional pain activities for our pharmacists on all the other units. And communication became a problem. How do we keep everybody updated? How do you remember? I've been working my off shift and maybe in Central for a couple weeks. I'm back up on orthopedics. What is it again? How does the protocol work? Communication is key when you have a large area and you're making a lot of changes. Levi Hall, one of our clinical specialists, he's our internal medicine specialist, but he focuses a lot on pain, did a phenomenal job, and I just wanted to show you this as an example. This is our internal website, our Beaumont internal website. You can't see it, I apologize, it's off the screen. But this is our pharmacy website, and we've got multiple different links in here. But he developed a pain management resource tool on our internal website. We're going to eventually maybe broadcast this throughout the hospital, but we're keeping it internal now. But the key point is that he has put in place here a unit-based pain approach. So we're working right now on the ortho. So once we get the orthopedic process for our pharmacists and how they're going to educate and be involved in pain management, this link will bring you to all the tools that you need. And then we're going to be developing it for all of these other areas. Once we did this, for the pain initiative, now we're looking at actually developing an internal unit-based services website where you can go out and link out to what are the initiatives that we're doing on this nursing unit. So again, it's that communication tool that's really key. And it was also bringing the pharmacist to the table. It was great. We have a Rehab Integration Council meeting, and there was a separate spin-off of that. They were talking about our pulmonary mobility unit. The physicians were the PM&R residents and our main PM&R physician and our nurses. And so Diane brought our pharmacists who were doing the inhaler teaching there. And there was a poster we didn't even know about that had been presented at one of the physicians' national organizations that talked about the success of our PMU unit, our reduction in length of stay, and it specifically talked about in there, one of the items it talked about was the inhaler teaching by our pharmacists. So it was really neat. The pharmacists were like, wow, we were on a national poster, so it was really kind of cool. So I'm done talking about barriers with pharmacists. Let's talk about institutional culture. This was another statement that came out of the PPMI. And this statement is the insufficient recognition by healthcare executives, medical staff, nursing staff, and others outside the pharmacy profession of the value of pharmacists' provision of health therapy management services is a barrier to optimal pharmacy practice models. So how many of you believe this to be true, that we are not recognized by these groups and that can be a barrier? Yep. 100% consensus that this was a problem. So, and this is a challenge. It definitely is a challenge at any organization. My belief is you need to make sure that pharmacy's at the table at the right time. You need to keep your eyes and your ears open, everybody in the pharmacy, so that you can always look for opportunities. I don't think it just has to be the director. I think everybody needs to be watchful. I also think you need to know what changes are occurring in your health system and what can you do to assist with that. Our ability to recognize that the top hospital goal was to increase his nurses' time at the bedside, and we said, what can we do to support that, was a huge breakthrough for our department. It sounds minimal because it started with missing doses, but I'll tell you, in 12 months, we were back on nursing units. I was with the hospital president. We were watching what happened with the discharge of a patient, and we were realizing all the hiccups that happened. And it was a complicated discharge. The doc came in, wrote the discharge, left, and there were all these questions that were left unanswered. So we had to repage the doc. The discharge was delayed. The hospital president turned to a group of us and said, we need to fix this. And what he envisioned, and he wanted to try, so we tried it, was what we ended up terming was a care huddle. And that was if there was a potential sticking point or a difficult patient or a difficult patient flow happening, that anyone could call a care huddle, and it would be a multidisciplinary huddle at the bedside to clear up with all the practitioners. And the hospital president said, I want the physician there, I want the nurse there, I want the care coordinator there, and I want the pharmacist there. So I really truly believe, because we did what we needed to do to help with the hospital goals and showed the value and that we could change our model, because we changed our model based on that, that's why we're able to be at the table and do all these initiatives, and now an ACS patient cannot be discharged until a pharmacist actually reviews the chart. And I think that none of us can argue the fact that transitions of care is going to be so important moving forward. It is today, and it's going to continue to be more important as that acute care, hospital setting, ambulatory setting start to get really murky. There's no more fine lines. And really, when you talk about readmissions and us being penalized for readmissions, transitions of care can't be more important. So, I know a few of you have heard my story before, but I have to repeat it again. And I think I repeat this because I want to get the word out and I want people to think this way, but I also repeat it because it helps me remember this all the time. Whenever I'm in a situation where somebody asks me, can you help out with this problem? Can your pharmacist do X? Or what can you do about X? I was speaking with one of actually he's our chief of anesthesia. It was probably a year ago. We were just shooting the breeze, and somehow we started talking about managers and leaders. And we're talking about, who's effective and who's not. He told me a story that when he was in school or in his training, he had a very wise individual tell him something that he could never forget. And this is something I can't forget, and I continue to talk about it because I really think it's something that we as a profession can't forget. And that is, what his professor told him is that unsuccessful leaders, when asked if they can help or do something, their response is always started with, no, because. No, I can't do it because I don't have enough staffing. No, we can't do it because blah, blah, blah. But successful leaders start their sentence when they're asked to do something with, yes, we can do that if we do it this way. So I truly believe that we all need to start thinking that we can do it. We may not be able to do it exactly the way that it's being proposed, but we can figure out a way to do it. And that's the only way we're going to be at the table and we're going to be able to change our practice model and demonstrate our value. So I'm going to get off my soapbox, but I really, really believe this to be true. And I'm going to challenge you when you go out in the work environment next week to start to listen to how people respond, and I think you'll pick that out. So again, institutional culture, I do think another important piece is to leverage the Surgeon General's report. Has anybody heard about the Surgeon General's report? Yeah, a few people. Okay. This was done, or it was completed at the end of last year, and it was, I don't know, there was a letter of agreement, there was a letter of acknowledgement and affirmation by the Surgeon General after this report came out. It's a great report. The back of the report is, I think, everything, a summation of every single thing that's ever written that shows and demonstrates the value of pharmacist activities on patient care. And it's a great article to use, or a great report. I probably distribute it to 4 or 5 individuals responsible for our physician alignment, physicians who are in our legal department, you name it, I've been distributing it. The interesting thing was, though, I was able in September to listen to, I think a couple of us in the audience were there, listen to the individual who wrote the article. And what I thought was interesting is he was very, very specific about saying that we need to start saying that pharmacists manage patients whose condition is primarily, or whose condition, we manage patients' conditions whose primary form of treatment is medications. We don't manage medication outcomes. We manage patients' conditions that their primary way of treating them is through medications. So I thought that was really a nice way of kind of changing our thinking. But I would encourage you, you can simply Google Surgeon General's report on pharmacists, and it's like the top item. It's really easy to get to, so I apologize. I didn't put the link here. The third barrier I'd like to kind of pull you on is that state laws that limit pharmacists' scope of practice are barriers to optimal pharmacy practice models. How many believe this to be true? Surprised I didn't get more. It was 100%. I do think our scope of practice within our state, many states, is probably not up to date with what many of us would say we're practicing at. And I know Denise and I were talking beforehand, Denise Pratt, that we need to do some more things in Michigan to change our practice laws. We need to do things with our technicians through the Practice Act and for our pharmacists' scope of practice. But I'm not going to say much more on that because we could go on for another hour. So what kind of tools and resources are available to all of us if we want to delve into this initiative and really start changing our practice model or continue changing what we have already changed? And there's a whole host of tools and resources available. The PPMI website, there's a special website. You can get to it at ashp.org/PPMI, or you can simply go on the ASHP website or the ASHP Foundation's website. It's available as a link through there. You'll see that there are 3 buttons here. One is about the national dashboard related to the PPMI. The second is the hospital self-assessment, and the third is the state affiliate toolkit. I'm going to go through all three of these, and some other tools that are available on the website. There is going to be oops, sorry, that was too fast. Like I said, I'm over 50 and female. This is not good. There is going to be a 4th button out there. I'm going to talk about that in a little bit, which I think is really exciting. I can't wait to see that. Let's first talk about the hospital self-assessment. Has anyone done the PPMI hospital self-assessment? Phew, okay. Does anybody not know what the self-assessment is? Or doesn't want to say? Okay. This is actually a great resource, and I would highly encourage you, and maybe you don't know if your hospital's done it. In fact, some of my folks here may not know we've done it, but we've done it. Shame on me. It actually is a way for each individual hospital to go in and respond to a series of 108 questions. It sounds daunting, but it's not that bad. 108 questions to measure themselves against the PPMI objectives. Where are you at with technicians, technology, pharmacist practice, measurements, so on and so forth. So it really is a great way of really measuring your service. And what it is there are 6 sections, and there are questions related to each section. It's relatively easy to use. You would log in for your hospital. Only one person would do it from your site. At the conclusion of that, you get an assessment survey. Try to work this. That breaks each section down and where you rank. And it gives you a way of prioritizing where you should be focusing your efforts. It's a great starting point for a strategic plan going forward for changing your practice model, but it really gives you a very nice summary and kind of says you're there, you're not there, or you need to focus on this. But the really neat thing is that it provides an action plan based on your individualized self-assessment. So it will give you, and this is an example of a hospital, Laurel Regional Hospital, and this is one of the questions, and this is a list of tools and resources with links to webinars, PDFs, all kinds of files, tools and resources for you to use related to this part of the practice model assessment. And this is updated on a regular basis. I highly encourage you to use it. There's a lot of tools being developed to help all of us as practitioners change our practice model. I will also tell you, if any state has between 25 and 50 CERT hospitals that have completed the survey, ASHP can then do an analysis. So you could go out and say, I've done it, 25 or more than 25 hospitals in my state have done it. How do I measure up against the other hospitals? How do I measure up against hospitals in the Midwest? I'm happy to report that we have 49 hospitals in Michigan that have completed the survey, and I think that's to Denise's credit. We have actually a practice model initiative task force, and we've been doing a lot of work. We had our own summit here in Michigan, which I did not bring up, actually Denise and Ryan, and we really tried to get the word out. So the good news is we've had 49 hospitals complete the self-assessment survey, which gives us a marker in Michigan and helps us know where we can help you in advancing your practice model. The bad news is we still have about 143 hospitals that have not responded. So we need to get more hospitals in Michigan. I'm going to step on my bandwagon again. And in case you're interested, I have the list. So I have the list of those who did and those who didn't. So I was able to get that. So if you can encourage, if you don't know if your hospital's done it, ask. And if they haven't, ask why not and ask if you can help. The next resource on the PPMI website is the State Affiliate Toolkit, and this is one of those buttons. And this is really a toolkit that helps state affiliates push out the PPMI initiative and the self-assessment tool to all of their hospitals within their state. It's got some resources and tools to help the state organization do this. And there is now a link to a webinar, and I can give it to you later because I think I added this after the slides were posted. But there is a webinar, I believe it was done by Wisconsin, that can be viewed, and it's examples of how state affiliates have used the toolkit to spread the word of the PPMI. Okay, so how are we doing across the nation with having hospitals complete the hospital self-assessment? And again, having hospitals complete the self-assessment is valuable to us as a profession, so we know, are we moving things forward? Are we giving you the right tools you need? Where do we need to develop resources at the state or the national level to help hospitals? And this is just a color-coded grid, and what you'll see is the 2 hospitals in green, the 2 hospitals in green, Wisconsin and Maine, lead the pack. They have more than 50% of their hospitals participating. The next in line would be Utah, New Hampshire, Michigan, Delaware, and Maryland, with 25 to 50% of the hospitals participating. And I think, Dan, we need to have a Maryland-Michigan race to see who gets green next, right?
Fair enough.
Fair enough. And there's only 2 states where we have yet to have a hospital completed, and that's Wyoming and Alaska. All right, so the button on that PPMI website is the national dashboard. Every year, ASHP sends out a national survey to see what practice looks like in hospitals across the nation. And this is the results in 2011, what ASHP did was take the PPMI, if you will, what came out of the PPMI and the national dashboard and figured out how do we merge the information together. So what you'll see at the top, the 5 goals are really the main points that came out of the PPMI. And the dashboard or the dials at the bottom are from the national survey, pharmacy survey, the questions that relate to each of these goals and where we're at with the responses from that national survey. So they're not a one-to-one match, but they're pretty close, and it really is the national survey questions that link up to the PPMI. So from this grid, or these dials, if you will, you can see that our strongest piece, from a national perspective, at 57.6%, we have pharmacists' roles, pharmacists' roles, practices, and activities will improve medication use and outcomes, and optimize medication-related outcomes. So we're in the yellow zone. About 58, almost 59% of our hospitals responded that they do that. Our second highest is goal number 5. Pharmacists will demonstrate leadership in exercising their responsibility for medication use systems and will be accountable for med-related patient outcomes. We're about 55% in 2011. And the third area of more strength, I should say, although we're still in the yellow at 44%, is that pharmacy departments will utilize available automation and technology to improve patient safety and efficiency. So we're moving the dial on those. We still have some areas that we really need to work on. Goal number 2 is only at 19%, and that speaks to that technicians will prepare and distribute medications and perform other functions that don't require a pharmacist's clinical knowledge. And then we're at 23% related to that pharmacists and pharmacy technicians will have adequate training and credentials, which is kind of scary for me, for activities performed within their scope of practice. This was 2011 data. At the mid-year this year, Doug Scheckelhoff will be releasing the 2012 data. So if you're going to be at the mid-year, I'm not sure what program it is, but he will be presenting the newest data on the dashboard. What other resources are available on the website? This is a great website. This is a series of webinars that you can view on demand, and they all are related to things that have been published. So they're very good webinars. They all relate to the Practice Model Initiative. There's a variety of them. I think they're constantly adding new ones. So I take a look at that also. It's also it's a journal club series. So this would be a great tool to use with your own staff. To really, use it as kind of a webinar journal club and have people listen to it and come together and talk, just something that might be kind of another good way of getting people engaged. The ASHP Foundation does have a practice model initiative grants. The deadline is actually gone. The announcements for who gets these demonstration grants, I believe, will be early next year. Looks like, sometime next year. And my understanding is this is going to be repeating, so it'll repeat again next year. And these are demonstration grants of what you're doing to move your practice model forward. This is cool. This is the 4th button that will be out on the PPMI website, and I can't wait for this. And this is called, it will be called Pharmacy Forecast 2013 through 2017. And what it is it's intended to be a strategic planning tool and advice for pharmacy departments and hospitals and health systems. It will forecast very important future trends in 8 different areas that are likely to challenge us in pharmacy practice. It was actually based on a survey of some very future-oriented health system pharmacy practitioners, as well as analysis of other reports that are out there related to trends in healthcare that are going to impact pharmacy. These are the 8 domains that will be in the pharmacy forecast. Pharmacy practice model, pharmacy workforce, technology as it relates to medication use, healthcare delivery and financing, drug development and therapeutics, pharmaceutical marketplace, physician and nurse workforces, which I think will be very interesting to see what's happening to those workforces that can challenge us or provide opportunities for us, and finally consumer-driven healthcare. It's pretty exciting. It will be available on the ASHP Foundation website, the entire report, and I think within another week or two it will be out there. So I don't remember the exact date. I think it was around November 14th, but don't quote me. So I just start looking for it soon. So I think it's going to be pretty exciting. I don't think we've ever had anything quite like this before. They have this in other areas of health, the healthcare arena, but this is really going to be a great tool, I think, for all of us to start thinking in the future and where do we need to be. So I'm going to spend a little bit of time talking about the pharmacy technician role in the new practice model, because that certainly is an area, as you saw through the dashboard and even through some of the questions we were asking about what should the technician be doing. And I want to update you on where we're at with the technician initiatives and really also what came out of the PPMI related to technicians. So let's talk about some of the recommendations that came out of the PPMI. The first one is that pharmacy technicians who have appropriate education, training, and credentials could be used more extensively to free pharmacists up from distributed activities. I don't think any of us would argue with that. I hope not. Assigning medication distribution tasks to technicians would make it possible to deploy pharmacists to more actively manage patient therapies. These are the following recommendations of what pharmacy technicians with appropriate training should be doing. I'm going to do a few little survey polls with the audience. Technicians could be doing the initiation of MedRec by obtaining and documenting patients' medication information for pharmacist review. How many of you use technicians to gather patient medication histories? So do we. Good. That's great. We found a lot of success with that. They need to be well trained. They need to be very good attention to detail. But I'd like to, after the break, maybe share some stories with people. Maybe this will give you some ideas. Look around the room and see who's doing what. You might want to pick their brain during the break. Reviewing patient charts to identify medication allergies that require a pharmacist follow-up. Is anybody doing this? Yeah, we aren't at this point. I'm just wondering how this is going to play out. I know allergies alert us in the computer system, but we also have alert fatigue. I don't know if anybody's had that. And then finally, checking dispensing by other techs. Check. Is anybody in our state doing tech? Oh, good. Terry at Munson? A little bit? Yeah, a little bit. Where are you from?
Spectrum Health in Greenbelt. We don't use it for everything, but we do incorporate it where we can.
Okay, good. That's one of my interests. I think we need to do some stuff with our state board, so maybe we'll have to talk. Other tasks. Compounding routine sterile preps in conformance with well-documented procedures. How many people are using techs to compound your sterile preps? I would imagine most of us in Michigan do that. Dispensing meds with remote video supervision by a pharmacist. Do we have any remote dispensing? No, I haven't heard of anything in Michigan. I know that it's, what I've heard of it is more prevalent in rural hospitals, that a larger hospital might be doing some supervision, telepharmacy type activities. Scheduling patient outpatient clinic drug visits, or scheduling, outpatient clinic visits. I know Hartford did it for a while. I think they're still doing it for anti-coag. Anybody else use technicians? Good. Aaron Munson. Where are you from? Grayling. Good. Okay. Criteria-based screening of medical records to identify patients who may require pharmacist intervention. Is anybody doing this? I'm not doing this. I think this is a tougher nut to crack. Preparing clinical monitoring information, such as, I think, collecting lab values and that. Is anyone using a technicians to collect proactively? Oh, good, Jesse. Okay. Inspecting and replenishing med storage devices. I know we do that. And probably a lot of us use technicians to do that. And finally, managing controlled substance systems. I have that. Okay, great. A couple more. Managing patient assistance programs, medication assistance. Monson? Anybody else? Okay. Conducting aspects of quality improvement programs. Kind of depends on what you want to classify. Oh, good. Okay. Kind of depends on what you want to call as a quality assurance. What do you get?
We've used them for infection control to be some of the secret shoppers, if you will, for who's doing hand washing.
Oh, that's a great idea, Ryan. Okay, good. Thanks. Thanks. Terry, how do you use them?
Most of it is the unit inspection reports, etc.
Okay. Okay. So we've got unit inspection reports, and we've got secret shoppers on technique and hand washing and probably compounding and so forth. So we got a couple good examples. Managing pharmacy department information technology systems, including routine database management and billing systems. I know I've got kind of like billing, but I've got pharmacists still involved. Okay, some of those. Okay. And supervising other pharmacy technicians. Okay, great. Okay. All right, I'm getting the 15-minute sign, so I'm going to try to hurry. Okay. ASHP, some of the recommendations related to technicians that came out of the practice model is that ASHP should define the scope of practice, including core competencies for health system pharmacy technicians. We should develop uniform national standards for education and training of techs. Support optimal practice models utilizing techs, and that they must be certified. By 2015, Pharmacy Technician Certification Board should require completion of an accredited training program before any individual may even take certification exam. We're going to talk about this in a minute if I can speed through these really quick. We also came out of the practice model believing that technicians must be licensed by state boards of pharmacy. In my mind, from what I hear, that's still a little controversial, but that's the direction we're headed. I really think we need to get to training and certification before we get that. That's to me, the next leap. And all distributive functions that do not require the clinical judgment of a pharmacist should be assigned to a technician. And finally, there should be opportunities for techs to be specialized. Why is it important? We have over 400,000 technicians in the United States. Training varies greatly. Everything from someone being trained on the job with a high school degree to someone with a 2- or a 4-year degree who's certified. Registration is not required in all states, and the role continues to evolve as we shift more pharmacists to patient care. Why is it so important? Well, medication use is so complex today, and there's such a focus on safety and quality. There's a need that we have well-trained, certified technicians that can help us provide that safe care to our patients in all practice settings. And the existence of competent pharmacy technicians is going to be fundamental, absolutely a core ability that we have to strengthen and use so that we as pharmacists can get out and work at the bedside in those multidisciplinary teams, providing care that is appropriate to our patients. And we don't have a defined standard, so it's not a good state that we're in. The ASHP has a pharmacy technician initiative that focuses, I'm going to go through this real quickly, it's a partnership with ASHP affiliates. Michigan is an affiliate with that, and it really is to try to get the word out there and help legislate for technician certification and mandatory requirements for training and education. If you look at this real quickly, this is our current method of how technicians can become trained. So to become a pharmacy technician, 7.5% of the individuals go through an ASHP accredited training program, 9.2% go through a non-accredited training program, 5% are just trained through an employer didactic program, and 78% just get on-the-job training. Only 63% are certified, of the technicians are certified by PTCE, and 80% there's registration by the Board of Pharmacy. So, and then they go through all these different pathways to become a pharmacy technician. What we really envision is is that they go through an accredited training program, they become certified, and then they're registered with the Board of Pharmacy before they can practice. That's really what the objective is. So our position at ASHP is that we have well-qualified, competent technicians that are integral to safe provision in all settings. And to achieve that, we believe that those 3 steps that I just went through must be completed, and they should be completed in this sequence. This is just a quick grid that looks at where pharmacists, and this is based off the national survey, or technicians spend their time. You'll see that only about 8% spend their time in non-traditional activities, and this is a listing of what those non-traditional activities include. This is another quick grid that looks at requirements for PCTB as well as accredited training programs. And if you look down at this is by hospital size, if you look down at the bottom, about 63% of the technician staff are certified, which is a good thing. However, only 4.8% of the hospitals, right here, require it before training. So, and then this is the method of training. About 78%, kind of a reiteration, 78% of the technicians have on-the-job training with observation. This is just another way of looking at the percent of hospitals with technicians performing certain activities. You can see, the higher percent of things are the typical restocking of floor stock and ADCs and purchasing in that. And then if you go down here, a fewer number of hospitals actually are using them in patient assistance programs, dispensing with remote video, screening med records for medication-related problems. So kind of what we've all been talking about earlier. These organizations actually support the technician initiative and our need or our belief that through the organization that we need appropriate training, certification, and registration. PTCB did launch an initiative in early 2011. It was a summit where they focused on consumer awareness, resources, education, state policy, and testing. A group of practitioners, including pharmacists, technicians, academics, boards of pharmacy convened. And the recommendation that came out of the summit is that in order to sit for the PTCB, there should be a minimum period of practical experience. There should be a background check on that technician, and they should have completed an accredited training program. And then to be recertified, the recertification process is that the 20 hours the technician must obtain in CE over 2 years needs to be a pharmacy tech targeted program, that 15 to 20 of those hours need to come from state boards of pharmacy, NABP, or ACPE, and no more than 5 can be practical or employer-based education. And finally, which I think this is really neat, that they're recommending that at least 1 hour of CE needs to be in medication safety. I would applaud that. I think that's phenomenal. There's a new microsite out there that was developed by ASHP, but it really is not labeled as ASHP. It's intended to be a very neutral website, which really, the foundation of the website was from these 3 different areas, and its purpose is to just educate the public about pharmacy technicians and also educate anyone who might want to become a pharmacy technician. It talks about education training, what does it take to become a pharmacy technician, and what are the careers in pharmacy, frequently asked questions. So there's a website out there for that. And this is a picture of what the website looks like. All right, so what can you do as a pharmacy technician? I have a whole list of activities that I don't think I'm going to have time to, but basically it needs to make sure that you as a technician have evaluated where you are at with your own certification and training, advocate with your state affiliate, your state organization to help require that level of training and certification, but also to advocate for your employer, that we should only be hiring people who have the appropriate credentials, background training, and are certified to be a technician working next to you as a technician. So there's a host of things here that really encourage you what you can do if you're a pharmacy technician to advance the technician's role. So what's next? ASHP Foundation will soon be awarding a contract. I'm not sure if it's the end of this year or beginning of this year. I know that they've already got the proposals in for the development of a drug therapy management complexity score. And this score is intended to help all of us figure out where we prioritize patients that can benefit the most from a pharmacist providing drug therapy management. There's been a lot of interest in having support, tools, and resources to be able to present to the hospital executives why we need to be involved more heavily, more readily at the bedside in multidisciplinary teams here and there. So ASHP is in the process now of developing a whole host of things like business cases, webinars, slideshow decks that you can use to bring to your C-suite. So those are up and coming. The state affiliate, there is a seed money available to state affiliates if you want to bring in somebody from the outside who has done a lot in their state to promote the PPMI and help hospitals move forward. So there's some money there available to the individual state organizations to bring in and help their state grow. And then finally this year at the mid-year clinical meeting, there's a state affiliate program on Sunday from 1 to 4, and they're going to be talking about change management in practice model. It sounds like a great program. Although it's a state affiliate program, usually the affiliate presidents are invited, but it is open to everyone. So I can't spend a whole lot of time, but I think we can't deny that leading change is going to be really important. We've got a lot of change. If you haven't already been through a lot of change, you're going to be going through a lot of change. All of us are. Cotter in his article on leading change gives us 8 steps that are guiding principles that he believes that if you're going to have transformational change, you need to follow these 8 steps. And the first is to create a sense of urgency. And it's really interesting. What he said is, you need to make sure, if you're a leader, that 75% of your managers are afraid of the status quo. They think you're at risk. So I think that's really a good message, because I think it's true. So get that sense of urgency. Form a powerful guiding coalition. Get your staff involved. They are your coalition. Get your nurses involved, wanting pharmacists. Get your docs involved. Create the vision. Where are you going? What do you see as the vision? The PPMI, your self-assessment, that helps you create that really strong vision. It helps you guide through figuring out what does that vision look like. Communicate the vision. Communicate it to the staff. Communicate it to each other. Communicate it to your hospital. Communicate it to whoever you want to communicate. The more we talk about it, the more we believe it, the more we get people engaged in thinking about it. Empower others to act on the vision. This is what I kind of spoke about as our Beaumont program, where we really, really encouraged our staff to get involved and lead and help them understand the vision. Plan for and create short-term wins. When there are small wins, celebrate them. I happened to be up on a nursing unit, and this is just an example, and my staff does this all the time. I'm just giving you my personal example. I saw one of our pharmacists go in to a patient room, and we were really, really working on patient education. And I walked by, and I saw him go in the room, and I just kind of walked back. And it was so cool. He did exactly the right thing. He sat down, eye level with the patient, and had a conversation with the patient. Came out of the room, washed his hands. That was great. So that was a short-term win, and I made sure that I said, Tim, that was cool. Thank you very much. So I think those short-term wins are really important for all of us to get. Consolidate all those short-term wins to get bigger results. Share the stories. Try to move from, it worked well on one nursing unit, one group of pharmacists, let them share it with the next group. And then finally, institutionalize the approach. Link what you're doing, link your change up to what the organization needs to do and needs to accomplish. That's really what this is all about. So where do you fit in? I think leadership is key, and there's nothing that we can do more, all of us as leaders, no matter what your title is that we all need to be willing to change, reinvent practice models within pharmacy, and we all need a model of passion, a true passion, that practice model change is strategic, and it is the most important thing we're going to be doing in the next couple of years. And I'm going to conclude this with a quote by Bill Selmer, and he said that we can lead the change that we believe in, or we can just position ourselves to be forced to accept the change being put on us by others. The choice is clear. We're going to lead the change. Thank you.